So we are starting with the topic Top Mistakes in IOP Management by Dr. Aswathy. She is the Assistant Professor in Government Medical College, Thrissur. Over to you, Aswathy.
Good morning, all. To diagnose glaucoma, we need all of this. But the most important, I would say, is the intraocular pressure because that is the one parameter we can modify and manipulate. Therein lies the importance of tonometry. Are we doing it in the right way? And what are the common mistakes that we make while measuring IOP? Over time, we have had a lot of instruments to measure IOP, but one thing that has emerged as a favorite is the Goldman applanation tonometer. Even that is marked by a lot of variability in the biomechanics, corneal biomechanics, and a few newer ones like the dynamic contour tonometer and the ocular response analyzer has come up, but it's not much use because it's more expensive and a lot time consuming. So still our favorite is the Goldman applanation tonometer. As we know, the Goldman applanation tonometer is based on the Imbert-Fix law, that is force applied externally is equal to pressure within the sphere multiplied by the area of applanation. But the validity of the law requires that the sphere be perfectly spherical, dry, perfectly flexible, and infinitely thin. None of this criteria is met by the globe. So, what are the more common? That itself is a cause of error, and the most common error of this comes from corneal thickness. Because the mathematical calculation for GAT is based on the presumed average corneal thickness of 520 microns. And from various studies, we have come to know that the population the CCT can vary widely from 500 to 600 microns. So for every 0.7, for every 10 micron deviation from the average, we'll have an average error of 0.7 millimeters of mercury. Thicker the cornea, the higher the IOP measured, and thinner the cornea, the lower the IOP will be measured. This has applications in corneal refractive procedures. So, if the patient has undergone procedures like LASIK and PRK, that would cause a thinning of cornea leading to an underestimation of IOP, which can persist up to 1 year. Therefore, tonopen or ocular response analyzer may be more reliable in patients who have had corneal surgery. Another one is a corneal curvature. An increase of approximately 1 millimeter mercury will be there for every 3 diopters of increase in corneal power. And similarly, for corneal astigmatism, IOP is underestimated for with the rule astigmatism and overestimated for against the rule astigmatism, approximately 1 millimeter for every 3 diopters of astigmatism. How can we circumvent this problem? You can either rotate the biprism until the dividing line between the prism is at 45 degrees to the major axis of the ellipse, or you can take both a horizontal and vertical reading and get an average of the two. Now, if the patient has more than 3 diopters of astigmatism, it is better to align the axis of the minus cylinder with the red mark on the tonometer head, which would give a more accurate value. A scarred or irregular cornea distorts the fluorescein rings and make it difficult to estimate the IOP. So, if the cornea is thick because of additional tissue, IOP is overestimated. This similar is the case in case of band keratomyopathy, where the calcium present within the cornea makes it more rigid, and hence IOP will be overestimated. And in keratoconus and other ectatic conditions, which would cause thinning of the cornea, the IOP would be underestimated. But if the patient has undergone a C3R procedure, that would make the cornea more rigid, thereby causing an overestimation of IOP. So, in significantly irregular corneas, it is better to use tonopen or pneumotonometer or other devices if rather than Goldman applanation tonometer. And tonopen would be a good compromise because that is not influenced by the shape of the cornea in high astigmatism, and also you can, as the applanating surface is a very small one, you can take the measurement in an area of the cornea that is clearer. But the problem is that the peripheral cornea is thicker than the central cornea, and that itself would lead to slightly higher estimated IOP. And Pascal dynamic contour tonometer would be better because it is least impacted by corneal thickness, corneal curvature, or irregular astigmatism. In corneal edema also there would be thickening, but here the cornea would be more soft and squishy, and the epithelium of the edematous cornea is easier to indent than a normal epithelium. Hence the IOP that is measured in corneal edema would be lower. Now, position of Myers is very important. You have to adjust the inner edges of the two Myers. So, any of the differences in alignment of the two Myers should be dealt with accordingly. The thickness of the Myers should be approximately 0.25 to 0.3 millimeter. That is about 1/10 of the diameter of the flattened area. The broader the Myers, overestimation is the result, and if they are narrower, underestimation can happen. So if the rings are too narrow, ask the patient to blink twice, thrice, or you can add additional fluorescein. And take care that the IOP is measured within 1 minute of applying the fluorescein. And if the fluorescein rings are too wide, the patient's eyelids should be blotted carefully with a tissue, and the front surface of the prism should be dried with a lint-free material. Blepharospasm can also cause overestimation of IOP, even up to 80 millimeters of mercury. So the biprism, you should take care not to touch the lids or lashes because this stimulates blinking and squeezing. And if the tonometer tip touches the lids, the fluorescein rings will thicken, which may cause an overestimation. Now, some eyes, the fissure will be very small, dermatochalasis, long eyelashes, and blepharospasm, or even reflex or fear of the object close to the eye can all make the patient very difficult to open his eyes. So you'll have to manually open the eyelids, but if you exert excessive pressure on the eyelids, that can overestimate the IOP. And most of the patients, when they sit in front of a slit lamp, they hold their breath out of anxiety or poor positioning. And that will increase the central venous pressure because of Valsalva maneuver, and that will cause an overestimation. Similarly, if they're wearing tight neckwear, that can cause an overestimation. So ask the patient to breathe normally, make them calm, and loosen tight collars for the before positioning them on the slit lamp. Arterial pressure, coefficient pressure, if they go low, can reduce the IOP. And eye position, if the gaze goes more than 15 degrees from the normal, that can cause an increase in IOP, more in restrictive myopathies. Repeated measurements can reduce the IOP, so better do a gonio after measuring the IOP. Diurnal variation is very important in people who are having glaucoma. It may go more than 8 millimeters, so a single measurement may not suffice. Other causes of variability are also there, including fluid intake, and regularly calibrate your instrument. And another thing is digital tonometry, but that is very inaccurate and notoriously inaccurate. So, tonopen and NCT are other options for measuring, but they may underestimate or overestimate the IOP at other than normal pressures, excess, increased or lower IOPs. So, these are the tips to avoid pitfalls, and you take care of all these and you get a proper measurement of IOP. Thank you.
Thank you, Dr. Aswathy. That was a good presentation. I always feel that if you have too many instruments, too many types of instruments to perform a given procedure, then that means that none of the instruments are good enough. So you have to know about each instrument in detail, and then only you can get a near about reliable result. And second is you have to know about how to calibrate each instrument. Tonopen is so easy to use, but you have to calibrate it again and again to use it. With Goldman applanation tonometry, all of you would have felt to examine a short, stout person with a small neck, it is bound to give you a higher value. So things which, these are the problems, as Dr. Aswathy has pointed out, we have to come up with a better tonometer. Thank you.